Flaps. So flaps are a block of tissue that contain your innate blood supply. Pedicle is the base of the flap that contains your blood supply. So here we have your evolution of your skin flaps from simple to complex. So first we have your random flap. So what are your random flap? So they are your three sides of the rectangle which have no specific relationship to the blood supply. That means it's not raised on a known blood supply, and the length to breadth ratio is no more than 1.5:1. Then we have your axial flap, which are based on your known blood vessels. Then we have your island or pedicle flap. So what happens in your island or pedicle flap is that the flaps are swung around the stalk as shown in this image. Then we have your free flaps. Now these free flaps are isolated from your donor side and they're transferred to a new side and reconnected with the help of your microsurgery. Now another important term that we need to know is regarding your chimeric flap. So what are your chimeric flap? These are your multiple spatially independent flaps having an independent vascular supply, and all the pedicles are linked to a common vessel. So if you look at the image below, we have a anterolateral thigh flap having a separate pedicle for your skin and the muscle but connected by a common vascular pedicle. This is an example of your chimeric flap. Now a few examples of your local flaps which I have taken from your textbook of Bailey and Love, the exact images. So we have your transposition flap. So if you look over here, there is a defect and the flap is transposed around the pivot point covering the defect, and now the donor side could be closed primarily, or sometimes you would require a skin grafting to close it. Then we have a Bylow flap. Now this Bylow flap is used to close a convex defect, right, and a second smaller flap is needed to close the donor side. So you can see it is usually needed in your closing of the defects in the nose. Then we have a rhomboid flap. So this is a parallelogram shaped transposition flap, right. Now the tissue which is used to cover your tissue defect and rest your donor side is closed with the help of your primary sutures. Then we have your Z-plasty, which is an example of your true triangular transposition flaps which are interposed as shown in your given diagram. Then we have your bipedical flap. So it is a bucket handle flap that is supplied from both ends. It is useful to rebuild your lower eyelid. Then we have your rotation flap as shown in the image, where we rotate the flap to cover the defect and the primary donor side is either closed primarily or sometimes you might require a skin graft for the same. Now next we have few advancement flaps. So you can see over here a simple rectangular with or without Burroughs triangle excision is done at the base, followed by your primary closure. Then we have your V2Y advancement flap, which is used in your fingertip cut defects. And then we have your Y2V, where you have your multiple which are done by multiple to release the band scars over joint, and this is one of the most effective means of releasing your isolated band burn scars over your flexion creases. So Y2V is used for your releasing of your scar sites, whereas V2Y advancement is used for your cut fingertip, right. So these are your few other examples of your multiple V2Y plasty for your scar. Now moving down to the next important topic is your fasciocutaneous flap. So we have this fasciocutaneous flap classification which has been recently added in your Bailey and Love. So this classification is known as your Cormack and Lamberti classification, which classifies your fasciocutaneous flap. So you can see your first classification A is consisting of your multiple large perforators. Now an example of this is your Pontaine flap. Then you have your type B, where you find a single large perforator. So an example of your single large perforator type B is your scapular or your parascapular flap. Now then we have your type C, where you have your multiple small segmental perforators. An example of this is your radial or forearm flap. And then we have your osteomyofascial perforators, an example of this being your free fibular flap. Since this has been a recent addition in your Bailey and Love, please remember the name of the classification and at least one example from each type. Now similarly, there's been a classification added in your Bailey and Love for your muscle flap, which is known as your Mathis-Nahai classification. So if you look over here, type 1, it has a single vascular pedicle, the example being your tensor fascia lata. Then type 2, you have your one dominant with one or more minor pedicles, the example being your gracilis. Then you have your type 3, the example of which is gluteus maximus. You can see over here you have your two dominant pedicles. Then you have your type 4, which is your sartorial. So they have your segmental pedicles. You can see a lot of segmental pedicles over here. Then you have your type 5 classification, which is your latimus dorsi, which is your dominant with your several small segmental pedicles. So the questions that can be framed over here is, gracilis is the type of which flap as per your Mathis-Nahai classification. The name could be asked, or they could ask you a dual dominant pedicle is which type of muscle flap as per your Mathis-Nahai classification. Now, what are your advantages of disadvantages of your local flap? Now, benefits include your best cosmetic tissue match. It's usually a simple procedure and a local, and it can be done either in a local or a regional anesthesia. The disadvantages include your tissue shortage, scarring, and the surgeon may compromise the local resection in order to accommodate your local flap. Now, what are your causes of flap failure? So the various causes can be like the poor anatomical knowledge by the operating surgeon. Now, if you insert the flap with a lot of tension, that could compromise the blood supply of the flap. Then you have your local sepsis. Then tight dressing is another important cause that you often see for the failure of flap. Then you have your microsurgical failure because of the inappropriate anastomosis, and your tobacco smoking by the patient is another important factor for your failure of flap. Now, we had discussed regarding your free tissue flaps. So some common free tissue donor sites of your flap, which includes only muscle, includes your latimus dorsi, rectus abdominis, and gracilis. Myocutaneous includes your latimus dorsi and transverse rectus abdominis. Then you have your fasciocutaneous, which includes your radial forearm flap, scapular flap, lateral arm, anterolateral thigh, and your groin flap. Then you have your osseous flap, which is including your fibula and your forearm. Then you have your fascial flaps, which are your temporoparietal, and then there could be miscellaneous like your jejunum for your esophageal reconstruction, pectoralis minor like for your facial reanimation, and omentum for your chest wall or limb defects. Now, coming down to the advantages and your disadvantages of your free flap, the advantages being able to selectly exact the tissue that we need to move. So if we know the defect, we can actually select exactly the best tissue as per the defect, only takes what it is necessary, and it minimizes the donor site morbidity. The disadvantage is definitely it is a more complex surgical procedure. Now, failure involves the total loss of transfer tissue, and you would need to reoperate the patient, and it usually takes more time unless your surgeon is experienced. So, flap monitoring is very important. A traditional saying states that the patient should be kept wet, warm, and comfortable. So, fluid balance should be monitored for maintaining the hyperdynamic circulation, and Doppler is used to check your blood flow in flap, trying to early detect your any arterial blockade or your venous blockade or your congestion in the arterial or the venous system. Now, there has been an addition of your leech therapy, which is from the Hirudo medicinalis. Now, the saliva of this organism contains hirudin, which is an anticoagulant. It contains a hyaluronidase, which facilitates the anticoagulant penetration, and histamine, which causes your vasodilation. So it improves the drainage of flaps that are venous congested. it is not used in venous obstruction, as that would be requiring your surgical exploration. Now it contains Aeromonas hydrophilia, so it would require your prophylactic antibiotic therapy. So in addition to flaps, we would end this topic with a discussion of a small topic, that is your tissue expansion. So your tissue expansion involves placing a device which is usually expandable balloon constructed from a silicone. So it is placed under the tissue that has to be expanded and progressively enlarged volume with fluid, while your overlying tissue accommodates to the changed pressure. So you can look over here an example of your tissue expanded device. The basic purpose of giving you this image over here, as this has been asked previously in one of your exams regarding your spot diagnosis, identify the particular instrument. So this is your tissue expander and it is generally filled with saline. Now you have your tissue expansion. Your advantages include it is a well vascularized tissue, it is tissue next to defects, so likely to be of similar consistency, and the disadvantages include your multiple expansion episodes are needed, the cost of device, and high incidence of infection and extrusion. So this was in short about your flaps and your tissue expander. Thank you.